Welcome to Immunologic Emergencies. We're going to be discussing um, these competencies that go along with this topic. We're going to apply the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for the acutely ill patient. When we look at immunology, it's going to be the recognition and management of shock and difficulty breathing related to anaphylactic reactions. So that's going to be the biggest thing that we're talking about. We're going to discuss anatomy, physiology, pathophysiology, assessment and management of hypersensitivity disorders and or emergencies related to anaphylaxis. So when we look at around the United States, we have about 1,000 Americans dying of allergic reactions per year. So when we look at each of these, a lot of them are because of airway obstructions or cardiovascular collapse. So as we go through the lecture, we're going to discuss, well, how do they get to that point? Looking at anaphylactic shock, when we look at shock, the definition of shock is very important because our textbook defines shock as inadequate cellular perfusion or inadequate tissue perfusion. So we can see that allergy-related emergencies can lead to that inadequate tissue perfusion or cellular perfusion. Going back to the original definitions of shock, Dr. Gross defined shock as being the rude unhinging of the machinery of life, and that definition really brings it home. It really drives that, that puts that sense of urgency behind what we need to be doing for our patients when they exhibit signs and symptoms that are, that lead or point to the patients in some form of shock. All patients die from shock. All patients will progress through the stages of shock. The only ones that don't is those that are instantly destroyed. So when we look at these medical emergencies related to allergies, they're going to progress through those stages. Now, how fast they progress through the stages is all going to depend on the individual and their immune system. So we need to be able to treat these life-threatening injuries when we see them, all right? And again, anaphylactic shock is an immune system problem. So when we talk about the immune system, it's designed to protect us from foreign substances and organisms. So whenever we have that foreign substance get into the body's going to go on alert. And now it's going to initiate these responses to inactivate the invader. If you've ever seen the movie Signs, okay, there's a movie with Mel Gibson and Joaquin Phoenix, and there's a part in there where the young boy has asthma, and it shows the young boy having an asthma attack. He can't get his medications, he has a complete airway obstruction, and the alien tries to blow this poison into the young boy's face. And that poison does not get in and cause any damage to him because his body was already clamped down or shut down prior to that alien trying to give him that foreign substance. So when you think of that concept, that's what the body's trying to do. It's trying to stop this foreign substance from getting in, okay? And it all depends on the individual and what substance is going to cause them to have that allergic reaction. So when we look at the allergic reaction, it is just an exaggerated immune response to the substance. So for example, you get a new laundry detergent, okay? You put your shirt on the morning after you use that laundry detergent, you have a rash all over your body. That rash is that exaggerated immune response, okay? So it's not directly caused by an outside stimulus, it's caused by the body's immune system. And the body's immune system releasing chemicals to combat that stimulus. Now, these chemicals are histamines and leukotrienes. Okay, so when we look at what's going on in our patients, right, it is the histamines and the leukotrienes that are causing, whatever symptoms my patients might be having. So we know it's caused by the immune response. So this allergic reaction, depending on how the body's trying to combat the immune system, it could be mild, it could be local, or it can be a complete systemic attack on that patient. So when we look at anaphylaxis, okay, anaphylaxis is an extreme allergic reaction. Not only is it extreme, it's life-threatening, okay? And when it becomes anaphylaxis, it's because it involves multiple organ systems, right? It's going to involve the respiratory system, the cardiovascular system, okay? So when we look at those reactions, we just got to remember that it is life-threatening. We need to recognize it, and what is going to be a life-saving intervention to do to this patient. Okay? One of the things that we might hear is going to be wheezing. Wheezing is one of the most common signs that we might identify in our patients with anaphylactic reactions. Urticaria is another one. So we look here at the picture, we see those wheals throughout the body. They start in one area, usually the area that made contact with the substance, and now it spreads throughout the body. Okay. Now, so we're going to have this areas of itching, burning, right? And they're going to be multiple small raised areas, and that's urticaria. Or, what we call, layman's terms, is going to be hives. All right. Now, when we look at anaphylaxis, one of the things that we might find is going to be hypotension. Initially, we might not have that hypotension, okay? Or we might not know that it's hypotension because we haven't taken vital signs yet. But we might see it, as a patient having an altered mental status. As a patient, when they stand up, they might feel a little dizzy. Those might be the early signs that we see. And those may be a result of that hypovolemic shock. Because now I don't have fluid in the circulatory system where it needs to be. It's somewhere else. So some of the common things that we see, some of the common allergens that we might see is going to be insects and stings, insect bites and stings. All right. So when the insect bites a patient, it envenomates them. That envenomation process is that substance that's going to cause, that could potentially cause that exaggerated immune response. So this reaction, again, it could be local, just like a mosquito bite, right? It could start to spread, or the patient gets hives all over their body, and then they might have some respiratory issues as well. Okay, so it all depends on how that person individually reacts to that foreign substance. Some medications might cause some allergies as well. Penicillin. If I give someone a penicillin injection, then they're going to have that immediate and maybe even a severe reaction. If I give you oral penicillin, then that medication might take a little longer before you start seeing signs and symptoms. Okay. Now again, you might have an allergic reaction, after you become sensitized. So it's just something to keep in the back of your mind when we're questioning our patients and we're doing our assessments. Some of the other things you might see, plants. Okay, they have it on here: dust, pollens, and other plant material. Like what we experience almost year-round here. We have that yellow film on our vehicles. That yellow film is going to be that pollen that we might have that allergic or those allergies to. Again, food. The reaction to food is going to be slow again because it has to go through your GI tract. Most common is going to be shellfish and nuts. We look at some chemicals: makeup, soap, latex. In the past we had a big problem with latex allergies, especially those patients that were born with some type of medical issue and they underwent a lot of surgeries. So if I'm asking, if a patient's having an allergic reaction, get a good history from them. Because you might find that they may have been hospitalized multiple times and developed these allergies to latex through that. We look at insect stings again. The death from stinging insects far outnumbers the death from snake bites. Okay, it's more common that we're going to see this. All right, so just be prepared for that. A lot of these stinging insects, they have that small hollow spine projecting from their abdomen, and they go ahead and envenomate through that directly into the skin. We look at honeybees. Honeybees can't withdraw their stinger. Okay, it has a little barb on the end. It gets into the skin. It gets hooked. They fly away, and their innards come out, and they're hanging off on your arm potentially. Where wasps, hornets, fire ants can sting multiple times. But again, it depends on how that individual is going to respond to that foreign substance. You know, we look at ants again, they're going to sting once, twice, 3 times, they're going to do that. And again, the individual ant sting might not be that bad. But as we look at multiple or even hundreds of these bite stings, then that toxin could cause that allergic reaction. Okay, so some of the things we might see with insect stings, like we see in the picture. If you look at the picture, you see the wheal. All right, you're going to see that wheal. Again, it's going to be painful, swelling, hot. It might be red. And of course, you know, we might experience some itching. Simple things that we can do for it is apply ice, all right, and just monitor that patient to ensure that they're not having an allergic reaction or even an anaphylactic reaction. Looking at the stinger, if I have to remove the stinger, okay, then we want to use a credit card just like in the videos. Just make sure you're wearing proper personal protective equipment and that you're scraping that stinger away from you, because what if you're allergic to it? All right, so just be safe when you're doing that. And look at the stinger of a honeybee can inject venom for up to 20 minutes. All right, so let's go ahead and get that thing and let's scrape it out away from us in a safe manner and monitor our patients for any changes that they might be experiencing. Things we don't want to use is tweezers or forceps, okay, because I don't want to squeeze whatever venom's inside that stinger into the patient. All right, let's wash the area with soap and water. Let's remove any jewelry from that area, rings, bracelets, watches, just in case I have some swelling. And just monitor your patients for signs or symptoms of shock. And never withhold oxygen. Give them oxygen, 15 liters per minute, you know, and monitor their vital signs. We look at 5% of people have anaphylactic reactions from bees, hornets, yellow jackets, wasps. They account for 200 deaths per year. So when we look at this number, we have to make sure that we're getting a good history and we're looking for these signs and symptoms, especially if we get the patient outdoors with difficulty breathing or they were camping or whatever the situation may be. If you know it has that risk factor for them being stung by an insect, then let's not rule that out too early. So right here we're looking at the chain of events that occurs. So we have the bee sting, you know, the antigens trying to get into the body, you know, the body's releasing chemicals to try to stop that. You know, we're going to get that release of histamines and leukotrienes. And then now, because I have that exaggerated response, and now my patient's going into anaphylaxis, it's going to affect multiple organ systems. It's going to affect the respiratory system. Now my patient can't breathe because they're having bronchial spasms, vasoconstriction. The heart is going to decrease output, right? It's going to decrease that coronary flow. So I might get some tachycardia. And then the blood vessels are going to begin to dilate. Now, the problem with the blood vessels dilating is that all the fluid that's in the blood vessels is going to start to leak out and get into the third space. Now, when things start third spacing, it's going to go to the interstitial, the intercellular space, and that fluid is what we're seeing in the swelling. If the patient has a swollen tongue, that's that fluid. It doesn't belong in the tongue, it belongs in the circulatory system. Okay, so we have to understand what's going on inside the patient. How is it affecting the respiratory system so that we can better understand the treatments that we're going to do for our patients. Our patients might have some itching, burning, widespread urticaria, wheals, swelling of the lips and tongue, bronchial spasms and wheezing, tightness in the chest, coughing, and some dyspnea, varying degrees of dyspnea. They might just have, you know, just telling you they're experiencing shortness of breath, or we might see that patient having to work hard for each breath. Some of the patients might also experience anxiety, abdominal cramps, hypotension, you know, and of course, if I don't do anything for these patients, it's going to lead to respiratory failure. So we don't want to leave these patients untreated. If I think it's anaphylaxis, if I think it's an anaphylactic reaction, let's go ahead and treat it appropriately, quickly. So here's our patient assessment. This is probably one of the most important things for us is that scene safety. We got to make sure that the scene is safe. We look, is there any threat to me? Is there a swarm of bees around? You know, look at the environment. Okay, and if there's more than one person in that area experiencing the same symptoms, let's go ahead and get the right crew out here to come help them. Let's get a hazmat crew, or let's call and get some additional assistance so that we're not putting ourselves at risk. Because if we go into that situation, we're going to experience the same signs and symptoms, and we're putting our lives on the line at that point, needlessly. So we're going to follow our precautions. The minimum precautions that we should have, as far as standard precautions go, is gloves and eye protection. Consider some specialized resources if we need. Specialized resources could include an AirVac, could include ALS, could include calling, the specialized rescue team to come get these hornets or render them safe. And if we have to do that, let's make these calls, make these decisions early, because it's easier to cancel than it is to get someone there. And time isn't on our side. Because once these patients stop breathing, we have about 4 to 6 minutes before brain death starts to happen. After the 10-minute mark, brain death is certainly going to happen. So let's step in early and prevent further casualties, or let's try to prevent having a poor outcome. When we look at our mechanism of injury or nature of illness, this patient might have both because they became unconscious, fell and hit their head or what have you. Okay? But we have the nature of illness. We're going to look, is it an allergic reaction? Has any trauma occurred? What's the NOI? What does the patient tell me? Let's look for these bee stingers and other chemicals that might have caused this reaction. Let's do a rapid scan of the patient, right? Get that general impression. My general impression should basically be, is the patient sick or is he not sick? If he's sick, let's get ALS backup. And then let's start getting let's treat the life-threatening situation, and then let's start getting as much information that we can so that we can better provide for our patient. We look at anaphylaxis. We're going to have some swelling in the upper airway. My patient might have stridor. If I don't have swelling in the upper airway, I might have swelling in the lower airway. My patient might start wheezing. Okay, so we're going to look for these signs and symptoms. All right, make sure that their work of breathing isn't severe, and continue to monitor those patients. Put the patient in a position of comfort, all right, and allow them to breathe. Give them oxygen, and if I have to, let's go ahead and give them an injection of epinephrine. We're going to go ahead and consult our medical director, and we'll give that epinephrine, that auto injector. And then you look at circulation. The patient might have some hypotension. They might have a weak radial pulse. They might have a rapid pulse. They might have a cap refill that's greater than 2 seconds. All right. In any of those cases, let's be prepared to use BLS, protocols, and then get ready and have that AED just in case they have circulatory collapse. So what we want to do for our initial treatment is put the patient on oxygen, position them, maintain their normal body temperature, right? Keep the back of the ambulance kind of warm for them. All right, and then these patients, again, we're working against time. So let's go ahead and transport the patient. Bring all their medications with them and anything that might be pertinent. Now we want to get a good history. So we should have already taken care of the life threats. My patient should have oxygen on them. And now let's go ahead and identify what's going on. What is the chief complaint? What is the history of this illness? What are the associated signs and symptoms? We look at right now being able to do our sample history, signs and symptoms, allergies, medications, last oral intake, events leading up, and let's add an R on there to include risk factors. All right? Does the patient have a history of allergic reactions, or their family have a history of allergic reactions? Okay, and then that last thing, the pertinent negatives, let's try to figure out, well, what isn't there that we expect to be there? If I think it's anaphylaxis, then I expect to have some respiratory difficulties. If I don't, then that's a pertinent negative, So we're going to look at what are the pertinent negatives with this patient. All right, here's a good chart here that has all the different signs and symptoms of allergic reaction. So we'll go through a couple on the top. We have respiratory system, shortness of breath, sneezing or an itchy runny nose, tightness in the chest or throat, irritating dry cough. We look at the cardiovascular system, a decrease in blood pressure because the blood vessels are dilated, an increase in heart rate initially because the body is trying to compensate, and our patient going to have pale skin as well. Looking at the skin, to be flush, itching or burning, urticaria, swelling. Might have some cyanosis or pallor, and then again some tingling feeling around their face, mouth, chest, feet, and hands. And then some of the other findings we might see is that anxiety, that sense of impending doom. They think they're going to die. Abdominal cramps, headaches, itchy, watery eyes, dizziness, and then a decreasing mental status because of that hypotension. So we look at our sample history like we said before, signs and symptoms, allergies, medications, past medical history, last oral intake, events leading up, and remember the R. So it's a sampler. We'll get that R. Does the patient have any risk factors? And then we're going to go ahead and figure out, does the patient have any respiratory symptoms? Do you have any other symptoms? Have you had any previous allergic reactions or asthma? Any hospitalizations? What were you doing before this happened? A good question to ask too is, what did they do for you last time? Okay? And that's important because what if the patient turns around and says, I was intubated in the back of the ambulance? That's when we need to say, hey, let's get ALS out here. Or if I'm an ALS provider, hey, let's get our advanced airway kit out and just have it ready. Some of the things during my physical examination might be an increased work of breathing, use of accessory muscles, head bobbing, nostril flaring, grunting, okay? And all of those are signs of an increased work of breathing. And then maybe even I might notice some tripod positioning as well. Let's also take the trachea as well as the chest, apex to apex, base to base. I might hear some rhonchi, I might hear some wheezing, I might not hear everything because of the severity. If I have a patient with asthma or anaphylactic reaction and I don't hear any movement or any air moving in and out of their chest, that's a bad thing. Let's check their circulatory system, check their skin, and just do that once over on the patient. One thing I want you to notice is this is a secondary assessment. In the primary assessment, all I did was identify life threats, treat them in the order that I found them, and put the patient en route to the next facility. One thing to remember too is our vital signs, right? Get a baseline. Pulse, respirations, blood pressure, skin, pupils, oxygen saturation. Now remember, depending on if my patient's critical or not critical, like we said earlier, sick or not sick, I might either be doing these, if my patient is sick, I might be doing them in the back of the ambulance en route to the next facility. If my patient is not sick, then I might be doing these on scene, But either way, what I like to do is get my patients out of the uncontrolled environment as soon as possible, put them in a controlled environment, which is my ambulance, and start treating that patient. All right, looking at vital signs, let's repeat these vital signs because we're having respiratory issues. Let's get a blood pressure now. Let's get a pulse. Let's get a pulse ox. Let's get those things to monitor each of these different systems on my patient. When we get to the reassessment, let's redo the primary assessment. Let's look for any life threats, treat them in the order that I find them. Because if the patient starts deteriorating, it's going to be rapid, or it potentially could be rapid and definitely going to be fatal. All right, so let's monitor these patients and watch for signs and symptoms. Now, when we get to the interventions, what do I need to do? Okay. If I determine that this patient is having a severe reaction, then I'm going to have to do epinephrine. Mild reactions, I'm just going to support the patient, give them some oxygen, take them to a medical treatment facility. But no matter what I do, I'm going to recheck my interventions and make sure they are working. Now, if I give the patient epinephrine, right, or let's say if epinephrine is within my protocols to give, then what I'm going to do is take it, pop the yellow tab off the back, pull the safety cap off the front, and I'm going to put it right on the lateral aspect of the thigh, okay? I'm going to push until the needle depresses. Once the needle depresses, I'm going to count 1001, 1002, 1003, 1004, 1005, 1006, 1007, 1008, 1009, 10, okay? Now that is 10 seconds. when we're giving these medications, we might be a little anxious, our heart rate might be a little faster. So we might actually be counting like this: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And that's not going to give the right amount of time to get that medication into my patients. Now we want to communicate, right? We want to document everything that occurred. We want to talk to our medical director, med control, the receiving hospital, let them know what we found, let them know what's en route. Get everything written down. Remember, if you didn't write it down, it didn't happen. And then get those patients and those responses to the medical treatment facility so we can have a continuum of care and have a better patient outcome. You know, we talked about the severe allergic reaction or anaphylaxis. We want to give BLS, give them oxygen, transport to the hospital, reassess them every 5 minutes, and somewhere in there we should have given them an EpiPen. If that EpiPen isn't working, 10 minutes later, we can give another one. Let's put them in a position of comfort, right? If we work in a tiered response system, let's get ALS en route. All of these patients that had some type of altered mental status should be transported, okay? And if they're not transported, if they want to refuse, make sure that they are informed of what they're refusing and don't just get the refusal. You know, look at what occurred to this patient. All right, if the stinger is present, scrape it away, give them ice, monitor your patients. When we look at epinephrine, it mimics the sympathetic system or the flight or fight response. And what it does is it increases the blood pressure, reverses the vasodilation, the hypotension, and causes the heart contractility and relieves some of the bronchospasm. So it's going to increase that contractility, and the heart will be able to beat as normal as possible. Okay, so the faster we can get that and on board, the better off our patients are going to be. You know, we look at these severe allergic reactions or hypersensitivity to something. When we find those signs and symptoms, be prepared to give epinephrine. Okay, right here we're looking at a twin jet. So with the twin jet, you can actually give 2 injections of this medication. And again, you want to cleanse the lateral aspect of the thigh. You want to place that red part directly on the thigh and push until it shoots off, and hold it for 10 seconds. Now we look at the adult EpiPen. It delivers 0.3 milligrams of epinephrine. The infant child system delivers 0.15, which is about half. Okay, so let's go ahead and if we recognize it, let's give them the epinephrine. Some of the side effects you might have with epinephrine: high blood pressure, increased pulse rate, anxiety, tachycardia, pallor, dizziness. These are the things I want to happen, okay, because I know that those are the side effects of adrenaline. So adrenaline and epinephrine are synonymous. Some of the things they might have is going to be chest pain, headache, nausea, vomiting, and we want to watch out for that. Continue to monitor your patient. Now remember that the foreign substance or the antigen or the allergen, whatever it is, that outlasts the epinephrine in most cases. So I might have to give them another dose. And usually, depending on protocols, the max dose is 3 that we give in the field. And at that point, if I've given 3 and I don't have any changes, let's make sure that we call our med control and let them know what we're dealing with. All right, so in summary, when we come back and we look at allergic reactions, what are they? It's a response to the chemicals the body releases, and those are called allergens. Allergic reactions occur most often in response to 5 categories of stimuli: insects, bites, stings, medications, food, and plants and chemicals. Reactions may be mild, local, only involve itching, and some can be severe and systemic and cause my patient to go into anaphylactic shock, which is respiratory failure, cardiovascular failure as well. Anaphylaxis is life-threatening. 90% of patients that experience anaphylaxis potentially could die unless they have some type of intervention medically. Wheezing, of course, and skin wheals are the first signs that we usually see. You know, people that are allergic to bees, hornets, yellow jackets, or wasp venom, they can have their kit, their epinephrine, their auto-injector, and keep it with them, you know, just in case they need it. We want to make sure we check our patient to look for flushing, itching, swelling, hives, wheezing, stridor, persistent cough, decrease in blood pressure, weak pulse, dizziness, abdominal cramps, and headaches. So just continue to monitor them. And again, the one thing that we can do that no other medical provider can do, you can have 10 doctors on the scene of an anaphylactic patient, and the only person that can transport them is us. So remember, transport is going to be our number one priority because these patients are going to need a higher level of care. So if I'm not doing a life-saving intervention on scene, then I need to be moving that patient to the back of the ambulance in a more controlled setting. And monitor your patients. Be alert for any airway compromise. All right, so we have just concluded our immunologic emergency lecture. We covered anaphylaxis, which is the big thing. We covered how to give an EpiPen, and now we're going to take a quick test. All right, so pull out a piece of paper, number it 1 to 5, and here's your exam. The signs and symptoms of an allergic reaction are caused by the release of which chemical? Number 2, the negative effects associated with anaphylactic shock are a result of, and y'all probably saw the answer of that one already. Number 3, you were called to a local basketball park for a 23-year-old male with difficulty breathing. He states that he ate a package of peanuts 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread urticaria, tachycardia, and a blood pressure of 90/60. You can hear him wheezing even without a stethoscope. You should be most suspicious of A or an okay. You were called to a local basketball park, you were called to a local baseball park for a 23-year-old man with difficulty breathing. Oh, we already did that one. Let's go to number 4. What is a wheal? And number 5, you're treating a woman who was stung numerous times by hornets. On assessment, you note that some of the stingers are still embedded in her skin. You should do one of the 4. All right, my friends, this is the end of our training evolution. Thank y'all for watching the video. Thank you for taking the test. If you have any questions, please email me at paulo@prime, PRIMELOGICCE.com. Again, that is paulo@primelogicce.com. Or you can like us on Facebook and ask any of your questions through there. I will be sending you an evaluation form. If you could please fill that evaluation form out. As soon as I get your evaluation forms, I will send out your certificates to you. All right, once again, thank you and have a great day.